Good day everyone, this is Doc Franz and welcome to our case discussion on diabetic polyneuropathy, which is our first case for pharmacology lab. So the first portion of our analysis tackles the history, and this just tells us how the patient described his symptoms. So let me read to you again the case. Our case is a 61-year-old male complaining of extremity numbness. The history started 2 years prior to consult, which means the numbness over his extremities started 2 years ago. He noticed it while working as a tricycle driver when he noted gradual, persistent, and thickened sensation on both feet. And he described it as parang may pad na makapal under his feet. This is associated with pins and needle sensation up to the level of the ankles. So again, there is a thickened sensation at the foot pad plus pins and needles at the levels of the ankle. This causes the patient to have some sort of ataxia, nakakalito habang naglalakad, and with increased frequency of tripping. This means that because of the sensory deficit, the patient has a difficult time navigating the process of walking. 1 year prior, he also noted similar thickened pins and needle sensation on the palms. So again, started in the feet 2 years ago, and then 1 year ago, it involved the palms, leading to poor control of the accelerator of the tricycle. Of unrecalled onset, these peripheral extremity symptoms were on top of lethargy and polyphagia. So the lethargy, lack of energy, and polyphagia, which he described as an increased meal frequency of up to 5 meals a day without satiation, were occurring for the long period of time before the thickening of the soles and the palms were noted. Recently, just 3 months ago, the patient also had blurring of vision as near as 1 meter, which means 1 meter and farther, the patient will not be able to see clearly. So you have to understand that this patient works as a tricycle driver. He earns his income by driving a tricycle, and that means he has to have a feel of the brakes, has to have a feel of the accelerator, plus be able to see where the tricycle is going. And so these symptoms impair the patient's ability to earn a living. He did not disclose to family and delayed seeking help until this morning when he heard of a free consultation at the barangay. So, with these points in the history in mind, what is important for us? The age of the patient, the onset of the symptoms, his work, the quality of the symptoms. It's gradual, persistent, thickened. Okay? Where? On bilateral feet, with pins and needle sensation at the level of the ankles. And that causes the patient to trip. And then, 1 year later, there is pins and needle sensations now on the palms. This is associated with lethargy and polyphagia, and now involves blurring of vision. So the first point of discussion is the pathophysiology of diabetic polyneuropathy. So how does the nerve get damaged with high levels of blood glucose? There is first hyperglycemia, and that damages the capillaries. A damage to the capillaries would mean decreased blood flow to the axon, and that leads to decreased axon transport, which means that the products produced in the cell body of the neuron will have a difficult time traversing the length of the axon. This leads to axon atrophy. So the axon actually degrades, it becomes damaged, and it decreases in size, and that leads to decreased nerve conduction velocity. The transfer of electrical impulse along the length of the axon is impaired. And this leads to the signs and symptoms of neuropathy. Another mechanism is increased nerve glucose. And all of these glucose and fructose will be shunted into the polyol pathway, and that leads to an increase in nerve sorbitol. This increase in nerve sorbitol will then decrease nerve blood flow. This increased nerve sorbitol will also decrease nerve sodium-potassium pump, which means that the nerve will not be able to spew out sodium into the extracellular fluid and reabsorb potassium from the extracellular fluid into the inside of the nerve, which means that the nerve will have a difficult time repolarizing or returning to the basal negative state, which means that the nerve will not be able to respond to further stimulation because it stays on a more positive charge most of the time. So that leads to decreased nerve conduction velocity and signs and symptoms of neuropathy. Next, this picture shows us the gloves and stocking distribution of neuropathy. So in diabetic neuropathy, because the insult is systemic, it involves almost all the nerves of the body, and it has a particular predilection for sensory nerves and motor nerves supplying the distal portions of the body, which includes the upper and lower extremities. In particular, in diabetic polyneuropathy, it involves first the sole and the digits of the feet, and then it goes to the ankle, and while the ankle is starting to get involved, there will also be initiation of the polyneuropathy symptoms at the hands, and it progresses upwards. So again, those symptoms include pins and needle sensation plus decreased sensation. So you have hypoesthesia and dysesthesia. What other diseases did the patient have? That is answered by the past medical history. So we also note that this patient has pulmonary tuberculosis last March 2021, and he completed his therapy with anti-TB medications. So that's RIPES, right? Rifampicin, isoniazid, pyrazinamide, ethambutol, and streptomycin. So you have 5 medications for the first 2 months, and then you have four medications for the first 2 months, depending on the case, and you have 2 medications for the rest of the 4 months. So let me recapitulate that. If you have a high-risk patient, you start with RIPES, but if the patient is low risk, RIPE only for 2 months, and then RI for the succeeding 4 months. The patient does not have hypertension, asthma, and seizure disorders. This is important because the use of isoniazid actually depletes the levels of pyridoxine and therefore prevents the synthesis of myelin and neurotransmitters in the nerve. So this is a confounding factor. What really caused the polyneuropathy of the patient? Is it the use of anti-COX, or is it because of diabetes mellitus? That's why the note of the use of anti-COX for 6 months is important. Family history answers the question, what diseases commonly run in this family? So if the patient has type 2 diabetes mellitus, and we also are able to recall or note that there is also type 2 diabetes mellitus in other family members, then that will increase our suspicion that probably this patient um, has a higher predilection for diabetes mellitus, a longer standing diabetes mellitus, and therefore the occurrence of nerve damage. The personal and social history will tell us what lifestyle factors are important for this patient. So our patient has a 45-pack-year cigarette smoking history, which means that um, for uh, for a set period of time, number of years, the patient takes in 45 packs per day. So, so that's a product, right? In a year, every day, the patient will consume a total of 45 packs. So, this tells us that for the past years, while the patient was still smoking, he was a chain smoker. And that is important. Next, the diet is high in carbohydrates, and there is no formal exercise regimen. What is important here? Those three. Because we know that by taking in or using cigarettes, we actually increase the risk of cardiovascular disease. We increase the intake of reactive oxygen species, which further aggravates hyperglycemia and further increases the cardiovascular risk for this patient. The patient has a high carbohydrate diet, which means that we have an increased load of glucose that may not be properly disposed of when this patient has diabetes mellitus. And lastly, there is no formal exercise regimen. Healthy muscles are protective of type 2 diabetes mellitus. Next, we now look at the review of systems, and that answers, are there symptoms that can be referred to other organ systems which may support our initial impression of um, diabetes mellitus induced polyneuropathy? Or are there any other disorders that we need to be aware of so that we can check what the patient takes in as medications, or we can start medical therapy for undiagnosed disorders? So with this list, what is important for us would be rapid weight loss, because that supports the diagnosis of diabetes mellitus. There is no chest heaviness. Again, because diabetes mellitus confers with it an increased risk of atherosclerosis and therefore myocardial infarction or acute coronary syndromes. Of note to us is dysuria, hematuria, and hypogastric pain. Because with these symptoms, we have to note that, this patient is an actual patient that I encountered. And then with these symptoms, we actually worked up this patient and found out that this patient had bladder cancer. So with that, the patient was diagnosed with bladder cancer and underwent radical cystectomy. So his urinary bladder was removed. This patient does not have claudication or difficulty walking, and that is important because that is a sign of macrovascular complication with DM. There is no recent edema. Why? Because patients with diabetes mellitus will often have diabetic nephropathy, where they will lose protein through their urine, and the decrease in protein will cause water to stay outside of the blood vessels, and that will lead to edema. So we have this again, the major processes that occur in patients with diabetes mellitus. Let's start with the decreased incretin effect. Again, incretin is produced by small intestines, and it leads to an increase in secretion of insulin by the pancreas. So patients with diabetes mellitus type 2 DM will have decreased secretion of incretin and therefore decreased release of insulin by the pancreas. Next, on adipocytes, there is increased lipolysis, and this means that patients with type 2 diabetes mellitus will have decreased fat stores, but at the same time, they will have increased free fatty acids in the blood, which will further increase insulin resistance. Next, we have increased glucose reabsorption. Remember that the kidneys will filter plasma and they will reabsorb glucose from the filtrate back into the blood instead of releasing it into the urine. So patients with diabetes mellitus will have increased glucose reabsorption, which means that their kidneys are very much avid in reabsorbing glucose and therefore increasing glucose concentration. Their muscles will have decreased glucose uptake. Their fats, in particular, will release a lot of pro-inflammatory substances, which will again decrease insulin sensitivity. Their brains will secrete less acetylcholine and more norepinephrine, and that will lead to insulin resistance and higher levels of glucose in the blood. Their blood vessels will have decreased sensitivity to insulin, and that means that their lipoprotein lipase will not be as effective, which means that they will not be able to degrade triglycerides in the blood, and that will lead to high levels of triglycerides in the blood, hypertriglyceridemia. But at the same time, that will lead to deposition of low density lipoprotein in the blood vessels, and that leads to atherosclerosis or damage of the blood vessel. Okay? And that will lead to an increased risk of macrovascular complications. Complications on the blood vessels supplying the brain, leading to stroke, blood vessels supplying the heart, leading to a myocardial infarction, and blood vessels supplying the extremities, leading to claudication. Patients with type 2 diabetes mellitus also have increased hepatic glucose production, and therefore, the increased production of glucose by the liver confounds the high levels of glucose in the blood. It worsens the high levels of glucose in the blood. And lastly, patients with type 2 diabetes mellitus will have decreased insulin secretion by the beta cell and increased glucagon secretion by the alpha cell, all in all leading to hyperglycemia. So of all the physical exam that was presented to you, these are important. The vital signs are stable. And why is that important? Because diabetics, type 1 diabetics will have diabetic ketoacidosis, and that will manifest with an increase in respiratory rate, and often they will have shock, so they will have low blood pressure, and they will have an increase in heart rate and an increase in body temperature. Type 2 diabetes patients will have a hyperglycemic hyperosmolar state, which is a severe state of dehydration in the body, also manifesting with decreased blood pressure, an increased heart rate, and an increased respiratory rate. You have to note that this patient is wasting already. His muscles are being consumed and his fat stores are depleted. So this patient, when I saw this patient, he was asthenic, which means sobrang payat niya. He had temporal muscle wasting and interosseous muscle wasting. So in between the bones of the hand, there's muscles there, and those were already wasting already. So motor wise, so by contraction of muscles, it was okay, but the sensation was decreased in both upper extremity and lower extremity. However, when we tested the Romberg sign, so the patient was awake, first standing straight, awake. He was not uh, showing imbalance, and when we closed his eyes, he was also not showing imbalance. So the Romberg sign was negative, and that told us that the cerebellum was unaffected. So those are the important physical exam signs for this patient. And lastly, I'd like to discuss how metformin works. Metformin will lead to activation of AMP dependent kinase, and that will lead to a decreased activity of acetyl coenzyme A carboxylase, which means that the liver will not produce fatty acids because the rate limiting enzyme has decreased its activity. And that will lead to a decrease also of VLDL and eventually LDL, and an increase in fatty acid oxidation. That will lead to a decrease in hepatic fat accumulation and an increase in liver insulin sensitivity. An increase in AMP kinase will lead to an increase in muscle glucose transport, which means that the skeletal muscles will be more active in reabsorbing glucose from the blood. And that will also lead to a decrease in hepatic glucose production. All in all, that will lead to a decrease in plasma glucose and plasma triglycerides, which is beneficial for most patients with type 2 diabetes mellitus. And that is why, because of its important blood vessel, lipid, and glucose activity, metformin is the standard initial drug of choice for type 2 diabetes mellitus. So with this, thank you for listening to our case discussion.